Hello, everybody. My name is Fabio Gallerani. I'm the founder of the VDM project with Dr. Jerry Sebag. We're here connected in this important update regarding eye floater research. And the topic of today is YAG laser. And we have the privilege to have with us, first of all, Dr. Sebag. Dr. Sebag, hello, how are you?
I'm fine, thanks, Fabio. How are you?
Very good. Thank you for being here. And Dr. Sebag, I let you introduce our guest for this important topic. And over to you.
Thank you very much. Well, hello out there. Today, we're very fortunate to have with us Professor Paolo Stanga, who heads up the Retina Clinic in London. And we're going to spend a little time asking Professor Stanga about his perspective on the diagnosis and treatment of floaters, with special emphasis on YAG laser vitreolysis. Welcome, Paolo, and thank you very much for joining us.
Uh, Good afternoon, good evening here in London. Thank you very much, Jerry and Fabio, for this invitation. It's a real privilege to be able to be here with you today.
Thank you. Let's begin by asking, how long have you been treating floaters, Paolo?
I've been treating floaters for about 6 to 8 years now,
I see.
with both, well, I started treating floaters with vitrectomy surgery. I think the first one I did for floaters was in, if I remember correctly, in 2003, 2004, when we got 25 gauge vitrectomy surgery. And I clearly remember presenting at a meeting of the North of England Ophthalmological Society on vitrectomy for vitreous floaters. It was a full vitrectomy at the time, and with 25 gauge. And I clearly remember somebody standing up, somebody in the audience, asking if I thought it was acceptable to remove the vitreous to treat vitreous floaters. That's when I first started removing vitreous floaters. Then I wasn't looking at floaters with a scientific interest at the time. I don't think I realized at the time how influential floaters can be on a patient's vision and mental health. And I was concentrating on other types of surgery, like PVR or proliferative vitreous retinopathy or diabetics, artificial vision with the electronic epiretinal implant, and then gene therapy. And I rediscovered floaters about 6 to 8 years ago, and I was greatly influenced by the work of Dr. Jerry Sebag, of course, and here we are. It's an everyday type of consultation that we get at the Retina Clinic London. Complaints of floaters are a very, very common problem, and I think it's an increasing problem. I think the main problem that people have is that they still don't know that floaters can be treated. So people are surprised when they get to know that floaters can be treated.
How do you typically diagnose and evaluate a patient who comes in complaining of floaters?
That's a very, very good question. We, of course, we take the time when we do a very personalized care at the Retina Clinic in London. We take our time with each patient. I think it's important to chat with the patient and listen to the complaints, the concerns of the patient, especially patients suffering from vitreous floaters, because they feel that doctors and surgeons don't listen to them, that they are constantly being told, well, it's not a big problem, it's not going to make you blind, and you have to learn to live with them. So they feel very, very frustrated by this. how do we diagnose vitreous floaters? It can be challenging because not all floaters need to be visible to the examiner to be symptomatic, but we rely on a multitude of technologies and techniques, including, of course, biomicroscopy, where we look at the inside of the eye through the slit lamp with through a handheld lens. But we also use contrast sensitivity, we also use ultrasonography, we use OCT devices, several technologies in hand.
I'm curious to know, are the majority of your patients older or are many of them younger patients?
It goes by waves. We used to have a lot of younger patients coming to see us. Currently, most of the patients that we see are in their 40s and 50s. That would be the majority of our patients between their 40s and 50s, in their 40s and 50s.
I understand. And you mentioned that you began doing surgery when 25 gauge instrumentation became readily available about 8 years ago. And I understand that fully because that was a similar experience for me. I actually began about a dozen years ago, but very slowly, very tentatively, because I wasn't really sure it was the right thing to do. When the 25 gauge instrumentation was readily available, it became easier, faster, and safer, especially with the limited vitrectomy techniques that we utilize. So I had a very similar experience to you. After that, it became exponential, and we've now got 326 patients that we really recently analyzed who we performed vitrectomy on. But that's the subject of another discussion. When did you start to employ YAG laser vitreolysis to treat floaters?
I started using YAG laser vitreolysis in 2018, if I remember correctly. And then I started very, very slowly. It was, it has its learning curve, as you know, and few people were using it. It was mostly used by anterior segment surgeons, not by retina specialist or a vitro specialist as the two of us. It was mainly used by anterior segment surgeons. And I started very, very slowly trying to increase my experience, my expertise. And then COVID came. So it was like almost 2 years when we slowed down with the treatment of, with the use of YAG vitreolysis. And now we have this study we are both part of, where we are looking for the best candidates for YAG vitreolysis. It's approximately 2018 that I started using YAG vitreolysis. And nowadays, yeah. And nowadays,
sorry, Paulo.
Sorry, no. Nowadays, we do cases on a weekly basis. We also do surgery, of course, same as you do, inspired by your work on using limited vitrectomy.
Indeed, yes. I recently had the privilege of visiting the Retina Clinic London and observing Professor Stanga perform YAG laser vitreolysis on patients with floaters. And I was very impressed by your setup, by the way you evaluate patients and the way you treat them. It's a top-notch operation. But I'm curious, what motivated you to get involved in the project that we're working on together now?
That's a very, very, well, first of all, thank you for your kind comments. It's a very pertinent question. Yeah, I believe in the importance of offering patients choice of treatment. I think we have to be able to offer the full range of therapies to every patient. I think it is wrong to say this is the only available therapy for your problem. Usually there isn't a best treatment for a condition. Most conditions there are usually multiple forms. There are hundreds of ways to skin a cat, and the same to treat diseases. And everybody has a preferred way. So I think it is important to be able to offer patients the full variety of treatments that are available. And for floaters, we can do YAG vitreolysis. We can do nothing, of course. We can, which is observation. We can do YAG vitreolysis. We can do a full vitrectomy. We can do a limited vitrectomy. So in my case, I discuss all options with every single patient. And some patients prefer one, some patients prefer another. I have my views on perhaps which one would be better for different types of floaters, but that's why we're doing the study at the end of the day.
Just so that the audience understands, Professor Stanga and I are collaborating, I at his invitation, on a project that is approaching YAG laser vitreolysis with very scientific, rigorous methodologies to evaluate patients before treatment, during, and then after treatment. And this is the first time that anyone in the world has tested YAG laser vitreolysis in this rigorous fashion. The advantage to patients is that it is, as I just said, a rigorous scientific approach. They'll be contributing to the wealth of knowledge concerning do patients respond, which patients respond, how much do they respond, etc. And another added feature is that it's being underwritten by industry so that at least during the course of this program, there will be no charge to patients who qualify and become enrolled. Professor Stanga and I started this several months ago. What's been your excuse me? What's been your initial experience, Paulo, with this approach to treating floaters?
I think that so far it's going very well. We are halfway through in recruitment. We can recruit up to 50 patients at each site. And as you correctly said, the advantage to the patient is that they receive treatment free of charge. Not only they receive treatment free of charge, but they get full examinations over a period of 1 year from the time that they are screened for participation into the study. So far, the response appears to be very, very positive. Patients seem to be very pleased with the results. And I think what we'll find is that some patients are going to be very successful candidates or respond very successfully to YAG vitreolysis, and others will be more suitable for vitrectomy, depending on the type of floaters. But not everybody can have surgery. Not everybody wants to have surgery. So I think that it's going to be another weapon in our armamentarium in the fight against vitreous floaters.
I concur completely and can share my experience, which initially I was very skeptical. I have spoken publicly and published in the literature skepticism about the efficacy of YAG laser vitreolysis. But when Professor Stanga approached me and suggested we collaborate, what attracted me was the rigorous scientific approach. This was not just a shot in the dark. There were very, very clear-cut objectives and protocols as to how to do this. And I think that in his wisdom, Professor Stang has set this up in a way for success, because my initial experience in this program is surprisingly positive. As Professor Stang has said, I'm surprised by patients expressing happiness with the initial results. And it remains to be seen whether we can corroborate that with quantitative objective evaluation of vitreous structure and measurement of contrast sensitivity. But patients seem surprisingly happy. So there's something there. And I want to thank Professor Stanga for involving me in this program, because it gives us the opportunity, as you just described, to offer more than just vitrectomy. And I think that when all the dust settles and all is said and done, we will be able to match a particular individual with the right treatment for their problem. It's not one size fits all, and there's only one solution available. So I have had a very positive experience, just like you described. Tell me a little bit more about the procedure. Is it one time? Is it multiple times? How do you approach this problem with the YAG laser?
I'm glad that you asked that question. You've been working on this for many years, in this field for many years, and you've been laying the ground to make this study possible, of course. So it's a privilege to be able to do the study with you, Jerry. And what I think is essential is for patients to understand that this is not a 5-minute treatment. This is a treatment that patients may need more than one treatment session, sometimes up to 5. We spend up to 20 minutes in each session. And I think this kind of treatment is especially suited for patients that have well-defined, small, or not small, but well-defined, centrally located vitreous floaters, because we do the treatment through a contact lens, and the contact lens has a defined field of view. So it's difficult to treat floaters that are in the periphery, but patients who have centrally located floaters have a very, very positive response to the treatment. For example, patients with a vice ring, it's like miraculous. And sometimes in one session, we get rid of the vice ring of a centrally located floater. The patient finishes the treatment a bit dazzled and recovers after 5 minutes. And sometimes after 5 minutes after the treatment session, they no longer see the floater that has been troubling them for years. So it can be a very good option for some patients.
Do you think, Paulo, that some of the explanation for what you and I have experienced with the results in this program could be related to the fact that you and I are vitreoretinal surgeons who, for many years, have worked inside the vitreous body and have a different approach from general ophthalmologists and others in the community?
I think so. I think that's a very good point. I personally believe that this is a treatment that should be done by retinal specialists, vitreoretinal specialists, because at the end of the day, we are treating the vitreous. I don't think a patient would want me to do a corneal transplant. So the same as they wouldn't want me to do a corneal transplant, I guess they would want a vitreoretinal specialist to treat their vitreous floaters. So I think it is essential because I think, understand the vitreous better than a cornea surgeon, for example, who understands the cornea better than we do. We can examine the retina in a much more comprehensive. Retinal examination is essential. We need to identify any areas, any retinal lesions that could potentially give way to problems in the long term that may not be related to the actual laser treatment, but may be misunderstood at a later time as related to the treatment. So it is essential to do a very good pre-treatment, pre-laser examination. The same as if I was going to do a vitrectomy for floaters, I always do a good complete full vitreoretinal examination, which in my opinion, should include indirect ophthalmoscopy with 360 degrees scleral indentation.
Yeah. I completely agree. And another aspect that patients need to appreciate is that if they get YAG laser vitreolysis by a vitreoretinal surgeon, and for one reason or another it doesn't work, continuity of care can be provided by the same surgeon who can perform a vitrectomy should the patient decide after trying YAG laser that they're still bothered, it hasn't really worked to their satisfaction. It does not compromise the ability to do vitrectomy, and that can be done by the very same person. So I think continuity of care in this domain is very important in all domains, really, but particularly here. And so I appreciate your perspective on that.
Absolutely. It is what you're saying is absolutely right, because we don't need to eliminate all the floaters. Sometimes there are one or two floaters that are the annoying ones, if I can call it like that. So we may not need to eliminate all the floaters, but some patients may want uh, uh, a result that the laser may not be able to achieve in that case, and they can move on to a vitrectomy surgery, either limited or full, with continuity of care.
Right, right. I agree. I understand Fabio has a question for you, Professor Stanga.
I suffer every day of this terrifying disease, especially for your mental health, because mental health is what is affected the most. And from point of view of patients like me, there is always a young laser has always been labeled as, dependent on the ability of the practitioner to move the lens in a way that is effective. And there is this fear in the community of sufferer that if YAG laser fail to shoot the floater, it's going to affect the retina. So, Dr. Stanga, which improvements are on the site in the next years, or perhaps even right now, that can allow a professional like you to, use YAG laser in the safest way possible? Is there any artificial intelligence helping or any improvement in the imaging? If you have any news on that, will be very, very interesting.
I clearly understand your concern. However, my concern is as a surgeon doing the treatment is more in hitting the lens than the retina. So I'm more concerned about hitting the lens than the retina. I haven't had any case in which the energy has damaged the retina, because we don't treat floaters that are either too close to the retina or close to the lens. I think it is essential to make sure that the person doing the treatment uses a laser device designed for the treatment of vitreous floaters. We are not using a standard YAG laser. We are both, Jerry and myself, we are using a device that's been designed not just for YAG laser posterior capsulotomy, which is the most common YAG procedure being done, but also to treat vitreous floaters. So that is something that is very important for patients to understand, that not all YAG laser devices are the same. As the treatment becomes more widely accepted and available, industry, of course, will have a commercial interest in developing new technologies that will guide the treatment of laser, so that the laser can be more accurate, and we could perhaps one day track the laser on the floater itself.
Very
Yes,
interesting.
Fabio, that's a very relevant point, and I want to let our audience know that this is not just talk, that there are projects that are ongoing attempting to use existing imaging technologies to do exactly what Professor Stanger just described, and that is localize in 3 dimensions on the XYZ planes, and then focus the energy on that location to maximize the effect with the minimum amount of energy necessary. So there are groups out there working on this problem. I don't know how long it will take. I get that question from patients all the time, that they're impatient. They want to know, will it be available tomorrow or anytime soon? And it takes time to bake a proper loaf of bread. If you rush it or overdo it, too much heat, it doesn't turn out well. And so I beg your indulgence and patience. That is indeed why they call you the patient. And it would be something to look forward to, but I can't say when that will be. But we are working on that in response to Fabio's very good question.
Yes, and thank you so much, Dr. Sebag. I asked that because I was wondering, I mean, the community is wondering if an improvement of a technology that is already approved will be faster than a new technology coming to the market. So if this XYZ, you know, pointing to the floater come available, how long is gonna take to implement in a real treatment since the YAG laser is already approved as a treatment.
I think your point is well taken that one could dissociate a new technology for imaging and localization from existing technology for treatment. But to my knowledge, the people who are working on this are simultaneously working on new forms of laser energy. And that's going to complicate things, or not complicate, but make it more complex and make it a longer process for approval. Well, what's your opinion, Professor Stanga?
I fully agree with you. I think we need to wait. It's difficult to give a timeline at the moment. It would be very easy for us to say within the next 10 years, but work is in progress as we speak. So there are several interested parties that are working on trying to to track the treatment to track the laser directly on the floater, so that it is likely to happen within the next 5 to 10 years. But we need to wait. At the moment, I think the technology that both Jerry and myself are using is the most proven one.
Yeah, and
Very good.
I asked just a clarifying question, Dr. Stanga. Since you shared the possibility to identify the type of floaters. As a sufferer, when I see floaters, I see just two kind of floaters. One that is pitch black and they don't multiply. It looks like they were already there, but I'm not sure of that because my only testimony is that they don't multiply, they just appear in the field of vision as long as the vitreous liquefies. So it seems like they're somewhere and they just appear. And others that are the gray strands that just, get bigger and they get together, they clump. So how do you actually identify that someone is, I mean, the floaters are localized in the center of the vitreous so they can be eligible for YAG laser. Just wondering, how do you do that?
We can only treat with YAG laser the floaters that are visible through a contact lens, a specially designed contact lens. That contact lens has a field of view that is defined, and we can't change that. And that is one of the limitations of the treatment. We cannot treat peripherally located floaters. But we need to be able to see the floaters in order to treat them. We have to remember that the opacities that patients perceive are not only clusters of collagen fibers, but could also be interfaces between vitreous and fluid. Something that's very interesting that patients report is that it appears as if the effect of the laser is ongoing after the session for a week or two, as if the liquefaction, if I could call it like that, of the vitreous or of the vitreolysis itself is an ongoing process after the session has finished, because they see changes in their vitreous floaters and opacities for approximately 1 to 2 weeks, and then the opacities seem to settle. So we schedule the sessions every with a maximum window of 6 weeks interval, but I usually try to schedule them between 2 to 4 weeks apart to allow time for that process to continue.
Yeah,
I agree with that, and I've had a similar experience. As I mentioned earlier, I was skeptical, and I'm quite surprised by the degree of happiness associated with this treatment. And even in patients whom I didn't think I really obliterated anything. I didn't think I really broke up or minimized enough to make an effect, but they describe happiness. And so I think you're absolutely right. The shots that don't quite land where they're intended land next to where they're intended, and the liquefaction that's produced in the area causes a movement over the ensuing couple of weeks out of the optical axis and become less bothersome. So this is a very exciting adventure for me. And again, I want to thank Professor Stanger for inviting me to collaborate on this project. I also want to thank him very much for his time today and close by simply mentioning once again that this program is actively recruiting. Professor Stanger in London and at the VMR in Huntington Beach, California, we are recruiting patients and enrolling appropriate patients who qualify based on a variety of criteria into this funded program so that it's free of charge to patients and you get to be examined very carefully for an extended period of time. And so far, there's a chance that you'll be happy. And so I encourage you to contact us and come and be seen for consideration of joining this very exciting program. At this point, I'll turn it over to Fabio, and thank you very much for the opportunity to share with your audience our experience.
Thank you, Dr. Sebag. Thank you, Dr. Stanga, for this insightful story about how YAG laser can be effective in treatment if approached in a much more scientific way that will prove the efficacy and the safety of the treatment. And if you would like to enroll to this project of research, you can find they can find how do they enroll, Dr. Sebag? Let's give some instruction to connect with you and Dr. Stanga, and so who is watching this video maybe want to enroll and be part of the study.
Well, I think they can communicate with you through the VDM project,
Okay.
the website, vdmresearch.org. They can communicate directly with the Retina Clinic London, the one and only Retina Clinic London. Shouldn't be too hard to find. And in California at the VMR Institute in Huntington Beach, the website is vmrinstitute.com. And Paulo, what's your website?
Well, first of all, thank you very much for allowing me to be part of this VDM project. I feel privileged to be talking to the two of you today and the wider audience. Anybody that's interested in becoming part of this study through our clinic in London, all they need to do is contact us either by phone or email. If they look us up on the web, our website address is www.theretinacliniclondon.com. Or if they Google Professor Stanga, they'll find us very easily.
Perfect. We leave the contact details in the description. I thank you all for your time, and let's unite for clear vision. We need to unite and support research and cure floaters with a safer and most effective way. Thank you.